Our next presenter is Erica CRILLY. She is a nurse in the bleeding disorders program at the BC Children's and Women's Hospital. And she's going to be speaking to us about transition issues, so pediatrics to adults, severe to moderate phenotype. And so that's going to be an interesting discussion. Welcome, Erica.
Okay, thanks for the kind introduction. This opening slide is a picture, for those of you who haven't been to Vancouver, of the Burrard Street Bridge, which is actually one of the bridges between our pediatric hospital, BC Children's, and the adult hospital, St. Paul's. So I actually have a really cool card that I sometimes give our transitioning patients with a picture of the Burrard Street Bridge. So I thought it was very suitable to have as my opening slide. Okay, in the interest of time, I'll keep going. The objectives I've been tasked with is, first of all, to examine the impact of emicizumab and other coagulation therapies on the type of care severe and moderate patients are receiving in our clinics now as their profile changes to a more mild phenotype. And then the second is to examine and discuss the impact of emicizumab and other innovative coagulation therapies, that's a big mouthful for early, on the transition from pediatric care to adult care settings. So here we go. So what has changed? And again, we're focusing on the first objective here. Definitely with increased factor VIII, and factor IX levels, because we have phenomenal extended half-life factor IX products compared to what we had historically. Patients are having increased factor VIII and factor IX levels today. Definitely there's been a huge amount of less infusions for many patients. For our factor IX patients, it's been once a week for many, or even twice a week for little ones that are on different products. There's been a huge decrease in the burden of care for, in pediatrics, the burden of care is the IV infusion in many ways, and this decrease has been phenomenal for many of our patients. And that's kind of come now with increased activities. Kids are able to participate in field trips in a different way. Patients are engaging in, especially in Vancouver, in more sports and more hiking, skiing, snowboarding, you name it. Definitely the range of activities and the intensity around activities has increased, and we're seeing, frankly, less bleeds. I think there's been several impacts that even in the short term we've started to see in our clinics, and I think our hemophilia treatment care focus, I really have been reflecting on how much it is changed even in a short amount of time. Definitely, I'm doing way less IV teaching and support. Families now that would normally maybe get a port inserted when their child was starting prophylaxis, or again, we'd be having them to come to clinic regularly for infusions prior to a port insertion, that's gone, right? That was a lot of hours of teaching and support and questions and phone and communication with other centers, and that is not entirely gone, but it's pretty gone compared to when we had over 20 children in our clinic with a portacast to now maybe 3. It's been a big difference. Definitely we have less focus on factor VIII inhibitors. I've been doing this care now for 20 years, and there's lots of patients I have cared about their inhibitor level each and every month on immune tolerance, and frankly, so have the families. And now with our previous inhibitor patients that are on emicizumab, do I care that your inhibitor level's 5 or 8 or 20 or 50? So there's been a lot of different focus and kind of different intensity in thinking about this. It's really been a huge difference in care. Definitely we're doing less PK testing. Sorry, Alfonso. This was right before COVID, something that a lot of the clinics and especially the nurses were really on, and having people come in for their time points and putting their PK values into WAPs and personalizing their treatment around that. But with novel therapies and especially emicizumab, this isn't something that we're doing in our clinics as much. And again, less bleeding, which means sometimes less support around bleeding, both serious and mild bleeds. Again, with these increased activities, I've already addressed this. People are able to do a bigger range of activities without bleeding. There's definitely more opportunity for people to be traveling abroad. They don't need to take the same kind of supplies with them for longer trips. It's easier. Vancouver's a very international city. Lots of people travel a lot from there, so that's really expanded travel for a lot of people. And I think what we're going to start to see is a bigger range of vocational pursuits for our adolescents, or kind of what they think they can go into now for persons with hemophilia. And I think also less anxiety and apprehensive to participate in school events. Like I've had patients that wouldn't have normally gone to summer camp, like not a hemophilia summer camp, that now are able to participate in a non-hemophilia summer camp. Like we're actually not having our hemophilia summer camp as much in BC because there maybe isn't as much of a need. There still is a need in many community ways, but for self-infusion. Procedure planning, definitely we've had less portocrat insertions, as I mentioned, but we've had lots more removals. But the removals have become less complicated in a different way because we have kind of a steady trough or steady state trough afterwards, definitely less hospital overnight admissions, and we're doing more community procedures, at least in our clinic, because we're a bit more comfortable in having patients not maybe be right at our center for some things. But there is increased complexity in perioperative monitoring for bigger procedures because it's harder to get levels. At BC Children's, we have to send our levels down to St. Paul's, and so we don't have as much ease in getting some levels while we're doing things. And lastly, this kind of leads me into the fourth impact that I think novel therapies have impacted the care and kind of leads to our second objective is really looking at transition. Now just for the basis of the audience, transition is really that purposeful planned process of moving from a pediatric center to an adult center. And I know many providers and patients here probably are cared for at lifespan clinics, but there often still is a movement to the adult care paradigm and maybe the treaters within that center. And this is still a time, even despite with these novel therapies, that I think that we have to care about. There is notable literature and papers and experience that this is a time where there's kind of patient safety risks. There's sometimes increased disease complications. Many of our patients that have been very well prophylacted as pediatrics, a grumbling ankle starts to rear its ugly head sometimes when you're 18, 19, 20. There's some psychological distress. Sometimes it's a time of lots of other change in our lives. Unfortunately, another time where, the onset of some mental illnesses start to occur. There can be non-adherence to regular medication regimens at this age. It's very well documented historically, and there can be a disengagement from health because frankly there's more exciting things going on in your life than coming to talk to the nurse that's known you since you were a baby. And I think our patients are really at high risk to minimize their condition in light of more important things, and especially in this light of kind of more mild phenotypes. Your condition and what you need to do for treatment isn't front and center as much. Prior to the pandemic, actually in BC, we had done a little bit of a project and a retrospective chart review on our mild patients, and I thought actually pulling out this knowledge was probably translatable a little bit. Obviously, it's a different population and a different time in what we're now thinking with patients on novel therapies with more mild phenotypes. We analyzed our cohort of patients that had transitioned from 2004 to 2014 and looked at kind of the risk factors for patients being lost to follow-up. And lost to follow-up was patients that did not attend an adult clinic HTC visit within a 3-year period after their final pediatric visit. And this was, Dr. Sun actually was working with Dr. Jackson's team and our team at the time, so that's where this data came from. In our sub-analysis of our mild hemophilia group, we found that only a third of the patients actually attended clinic after a year after transition, and only 56% had sustained follow-up. And we did find that the risk factors were really that longer gap between the transition period, like the last visit with us, the first visit with them, and less, interestingly enough, less frequent pre-transition visits. So as pediatric treaters, we think we've taught everyone everything they know and we don't need to see them as much, but maybe there's actually a need for us to do so. So I think this is really a call to action. And again, Dr. Sun has, well, it's not even that recent now, but published a paper that was a collection of, if you can remember, it was a Delphi method of Canadian treaters in talking about the important elements of transition care. And I think they're just as timely for us to remember and think about. And I think we do need to think about offering enhanced follow-up in the first year of post-transfer. So often when we see new infants in our clinic, we may see them every 3 months to get going. Maybe, I'm not saying you need to see people every 3 months in the adult centers, but maybe there needs to be a little more intensity in when you're intaking new patients. I think, as we know as pediatric treaters, we need to start the transition process early. We don't need to teach everyone everything they know in the last visit. We need to start when they're 8 and 9 and 10, getting them knowledgeable about their disorders, knowing how to manage their conditions, knowing I often talk to the kids about their elevator pitch that they need to have with healthcare providers, that they need to be able to practice and say. We need to provide independent assessments without the parents in the room early in adolescence, and this can be challenging with Zoom. And facilitate a gradual responsibility transfer. From the kind of adult side, our providers across Canada said that we need to address vocational choices and lifestyle and psychology issues. Again, our clinics don't have a huge cadre of social workers and psychologists that are able to support our patients, but this is a time when we need it. We need to provide early introduction to adult services, provide a good transition summary to the patients. I know in our pediatric center, we do provide a summary of your time with us. I often say, yeah, so if you become a rock star and you're living in Paris, you have your medical summary with you. Here it is. But I mean, an 18-year-old doesn't know what happened to him when he was 2, and it might be really critical to him giving that medical history as an adult. So it's important for us to do that. And we also really need to track outcomes. And there was a bit of call to action this morning for us to be doing proper data collection, and I think this is also the case. And I think the outcome measures that we really need to look at, and we found when Linda did this project, is we need to look at adherence. Adherence is important, and although we think, oh, these new novel therapies, they're such a breeze, they're so less frequent, they're such an easier route of administration, we're going to soon forget that sub-Q is still hard for people, and you still do need to be adherent, and people do still forget the day they're supposed to do it, and it hurts sometimes to do it. So adherence isn't the breeze that we think it can be. Is there a change in their ABR from baseline? And we need to measure that, at maybe pre-transition and after. We found that ABR did increase in this earlier cohort of patients when they were in this transition period, and we need to still be measuring it in our patients transitioning on novel therapy. We need to still assess self-efficacy skills, especially if patients are infusing home factor or IV fusions irregularly, and make sure that we've set up systems well to support them. Again, the hemophilia knowledge, sometimes we've done in pediatrics, we've done a lot of teaching with parents, and kids have not had the benefit of actually the rigorous teaching that we sometimes provide to their parents when they're first intaked into our clinic. And then, we also really spoke to this time cap between the last pediatric visit and the first adult clinic visit. And when you have severe hemophilia and you're ordering factor regularly and you're really engaged in having to connect with the adult clinic immediately because, hey, I need to keep ordering product and keep having supplies. With some of these novel therapies, there's not that imperative to kind of jump on it, perhaps. So I worry that the time gap can be more relaxed, and I think we need to pay attention to that. And I think we also need to measure and document kind of the number of hemophilia treatment-related hospitalizations or ED visits, because that can be a really powerful outcome to understand, to then be able to improve on for our patients in transition. And that's it, right under time.